Next, we move into TMJ treatment, and we're going to stop there So, moving on with TMJ treatment. We've been laying the groundwork, looking at the anatomy and the biomechanics of the jaw and surrounding area. Next, we're going to start evaluating TMJ. The first thing we do is we find a strong indicator muscle. And we test by having the patient bite down. Now, you might ask, how did we get to this point where we think we have a TMJ problem? Well, in the last group of slides, we looked at some of the presenting complaints, and we will learn when I demonstrate how you can be led to looking at the teeth and the jaw, say from other muscle tests. You might be, the patient may have a shoulder problem, or possibly a category, or some other kind of cranial. And so they may have a shoulder problem that brought them in the door, and you're evaluating the shoulder from all kinds of different angles. And at one point, you find that the TMJ, if the patient moves their jaw in some particular direction, or if they bite down or open, that you'll get a change in either a weak muscle going strong or a strong muscle going weak. That's a really good place to start. Aside from that, if you suspect TMJ, maybe from the history, maybe the patient has a history of teeth problems, maybe they have dentures. A lot of times they will tell you, yeah, there's a common one. My neck's really out, messed up because I was in the dentist chair for several hours the other day, and I haven't been right since. Well, right then and there, you've got a good indication. You've got this is an area you need to investigate, and then you go on and ask more questions. And anyway, so the first thing you're going to do is test the patient to see if they weaken, if the strong indicator muscle weakens when they bite down, without any therapy localization or any other kind of reflex involvement. And this would indicate what we call in AK neurologic tooth, which means there's some sort of disrelationship proprioceptively, anatomically, with the way the tooth is anchored into its socket, and the way that neurologically that tooth is affecting other parts of the jaw or even other parts of the body. Here's a quick reference slide for how the muscles relate to certain teeth. You can go over this. This is really handy if you find a neurologic tooth, you can go to the muscle related to that tooth and see if it's also weak. So it's a way of kind of cross-referencing and intersecting with other thought processes. Quick review of the TS line that we went over in session 5. You can see here too that we have points along the way. If you're palpating around the TMJ, you might also be palpating and finding positive TL with some of these points. And this is similar to the pattern of relationship that the teeth have with the muscles. So I put AK underneath there because it's, as far as I'm concerned, or as far as I've know with my involvement with this work, no one else uses the term neurologic tooth outside of the AK terminology that I'm aware of. If someone else does, I'd like to be enlightened. But so it's a term that's I think very accurate, but it describes in this slide, it says it describes this phenomenon where the tooth is say out of position, or somehow the periodontal ligament is being stressed in one particular direction. And as you remember from the homunculus, the incredibly large representation that the teeth and jaw have in the sensory and motor areas of the brain, the ligaments that hold the tooth to the bone of the jaw are what give are what provide the source of proprioceptive feedback. So when the jaw bites down, the stretch receptors in the periodontal ligaments, because it's a series of ligament fibers, feeds into the brain and tells the brain, oh, it's time to back off on the motor, as the signal increases. Also, there's a phenomenon which goes on in all of the entire myofascial matrix of the body, as well as bone and all connective tissue, the piezoelectric effect. So deformity is going on all the time with these small structures as well as larger structures, stimulating the ligament, stimulating the myofascial matrix that surrounds it, stimulating the bone. And if there is a problem there, then this becomes afferent input into the central nervous system. Another thing too is these fibers. You'll see this picture is it's fairly clear to understand, but you can see the fibers between where the D is pointing to the space between the A and the C section. Those little fibers of the periodontal ligament. They also provide a matrix of support and integrity to all the other supportive tissues, the blood vessels, etc., that support the tooth. So one of the common causes of tooth loss, of course, is a degeneration and loss of the periodontal ligament over time. So it's very important to keep these structures healthy, not just to hold the tooth in your head, but to maintain the neurological proprioceptive function that the periodontal ligament provides. So you want to look for neurologic tooth when a person has just been at the dentist. Maybe they just were hit in the mouth. Maybe they had some sort of trauma, sports injury, or maybe they got in a fight. Whenever there's been direct trauma, that's a real obvious time to check for neurological tooth. A real easy way to screen, once you have this positive response to them biting down, have the patient contact at the tooth gum line with their own finger, right on the tooth. Sometimes they want to touch outside the mouth, but I have them go right. And if they don't want to do that, then I'll have them, they can go wash their hands if they're more comfortable, or I'll give them a glove to put on, or I'll glove up and go in and touch it and challenge it myself. But usually they're fine with it. But they touch at the tooth gum line, maybe 2 or 3 molars at a time, coming on around. It's very quick to screen. If you get a weak indicator muscle with a TL to a tooth gum, or to say 2 or 3 teeth, then you go 1, 2, 3, and you find which one is the actual positive, like we would the pulse points. And then you challenge excuse me, you challenge the tooth buccally and lingually, and you look for weakening. Now, just like with a cranial or a respiratory adjustment in the spine, the way we correct this is you challenge one direction, creates a weak indicator muscle. You have the patient breathe in or breathe out, and then you correct the tooth in the direction of challenge on the phase of respiration that negated the challenge. There's a slide there that points that out. Now, with nutrition, you can also check nutrition. There's a number of different things. Zinc, of course, is a classic for teeth and cranials. Minerals, you can check for. I find that to be fairly handy. You can check for minerals to see what negates it. Also, you want to. Often you'll find these neurologic teeth, and you'll see that they've had all kinds of maybe dental work or damage, or maybe they've got a current inflammatory process going on. Often these are, or you will find things a lot using these techniques that will serve as a point of referral back to their dentist. So anyway, just to recap, so strong indicator muscle, have the patient bite, no TL. That indicates a neurological tooth, and you go through that protocol. Now, if you don't find anything with that, well, then move on. You will. You almost always will find something to work with. Now, strong indicator muscle weakens with opening, with no therapy localization. Now, that's going to be a situation that we call fascial flush. The need for fascial flush to the closing muscles. Fascial flush, remember from session 1, that's what we typically will use to treat the antagonist, the hypertonic antagonist to the primary weak muscle that we will fix with spindle cell, O&I, or GTO. And of course, the synergist we will treat with, in the classic triad of sprain strain, the synergist we will treat with strain counter strain. Same applies with these muscles. Our two main tools with the TMJ muscles are going to be fascial flush of the tight muscles and spindle up or spindle down of the hypotonic or hypertonic muscles. So we got basically those three, two techniques, spindle cell and fascial flush. Now, if we have a strong indicator muscle, patient opens their jaw and there's a weakness, we know that it's a need for fascial flush of the closing muscles. We don't know which ones. That's when we go to the closing muscles. We start with the masseter, and the patient will TL both masseters, and if it negates the opening weakness, or the opening causing the weakness of the SIM, then we isolate side to side, and that's the muscle that gets fascial flush. If, for example, it is the say the patient TLs the masseter, no change, then we have them TL the temporalis, and I'll have them spread out their fingers. I'll do this in the demonstration. Anterior, middle, and posterior divisions, and then we isolate which division and which side by TL, and we fascial flush that muscle. And that's now the other closing muscle that can be involved, of course, is the internal pterygoid. And the way that we TL that, if you see the yellow arrows that says TL, the patient basically I'll have the patient put their thumbs up inside the jaw, right at the angle of the jaw, and press up there as far as they comfortably can. The idea that they're accessing at least the insertion of the internal pterygoid. And so these are a little more tricky. You have to reach inside the mouth and gently at first. Sometimes you got to be a little more vigorous, but gently at first fascial flush that internal pterygoid. Not the most pleasant thing to have done, but it doesn't take long and it responds usually very quickly. Here's another kind of nutshell. Strong indicator muscle weakens with biting, no TL, think neurological tooth. Strong muscle weakens with opening, no TL, think fascial flush of any of the closing muscles. Strong indicator muscle weakens with TMJ with therapy localization, then your tool is going to be spindle cell down with opening, of course. Typically, we spindle cell down with the TMJ. Um, so with spindle cell, no, with TL, so we've say we've gone through the protocol, we've cleared either screened for neurologic tooth or found one and fixed it, and we move on to opening, found maybe a fascial flush, we fix that. Then we'll have the patient at therapy localized without any jaw motion. Now, a positive TL without any jaw motion, you may have pathology in the joint itself. There could be a problem with the disc, just like a subluxation will therapy localize quite easily with a single-handed TL. You may also have small intestine 19, the ending acupuncture point for the small intestine meridian is right at the TMJ. You may be TLing small intestine 19, so you'd want to go through and check your meridians as well. So that's where you start. So if that doesn't TL, then you go to the next step. You're still, patient is there. You can see where the green circle is there. It says therapy localized. That's where they're still TLing there the whole time. Have the patient bite down while they're TLing. That's going to be a need to spindle down the closing muscles. Now we may have just fascial flushed some of the closing muscles. Now we need to spindle down some of the closing muscles that are firing too intensely. That's going to be, then we go back through, we TL the masseter, 3 different divisions each side. The 2 divisions, superficial, deep each side. We TL the temporalis, anterior, middle, and posterior divisions. And then the internal pterygoid, same way, we TL those while biting. Before we were TLing them while opening. So we find which muscle needs spindle down, and then we go from there. This would be an example. This slide number 165 would be an example of how we would, the direction that we would direct our pressure to spindle down the masseter, for example, with the jaw closed. Here's an example of how we would spindle down the anterior, middle, and posterior temporalis muscle with closed jaw if we're going to go, I'll go over all this with a demonstration. And then eventually, someday, we're going to get to workshop it. You guys are going to become masters at TMJ. If you master this work, just this stuff that I'm teaching you in the basic course, if you really get good at this, it'll be a big ticket item. It's one of those evaluation procedures and treatment protocols in AK that you can build a practice on being really good with the TMJ. There's a lot of different disciplines out there that, like physical therapists, a lot of them are, work with TMJ. Some of them specialize in it and get pretty good. Most of them just sort of, they really, and most chiropractors really don't address TMJ much. They do a few things, a little stretching here, there, exercises, whatnot. For the most part, TMJ falls under the purview of dentists. They're kind of the logical, profession. However, it's really, they really don't work beyond their model of malocclusion. They really don't deal with the biomechanics or the neurology of the TMJ at all. They treat it like it's just an isolated problem. Usually their treatment's directed at trying to normalize bite. And they file teeth down and they put people in braces and all kinds of stuff. Anyway, whole other story. If you go back, if you look at internal pterygoid, spindle cell, down, that's a little tough. Usually you kind of have to just fascial flush it the same way. Just get in and try to disrupt the goop that's maybe interfering with the proprioceptive function. External pterygoid, the way to TL, as you can see in the little red splotch up there, that was called the pterygoid pocket. That's where the patient would TL while biting down to test for the external pterygoid. And with the external pterygoid spindle down, basically you take your smallest finger and you go up and you get in the middle of the muscle and gently kind of push just to give it a stretch. You're trying to reset. You can't get two fingers in there to spindle it down. You've got to just kind of get in there and kind of work it. And it's very effective. It really is. Once again, after you've done fascial flushing, spindling down, any kind of work, then you want to check the neurolymphatic reflexes. Treat as needed. Check the stress receptors, check the neurovasculars. I actually use these fairly often on the masseters. Just a lot of times just to calm down. If the patient's having a lot of pain in that area, it can be really, really calming. Once again, trying to nutshell it. TL, TMJ with biting down. This gets more complicated. If you deviate the mandible to the left, that's going to be the left temporalis, the right internal pterygoid. If you deviate the mandible to the right, that's going to be the right temporalis, left internal pterygoid. If you retrude the mandible, which you also test for, that's going to be both. It's going to be the masseter, especially the deep division, and the posterior temporalis bilaterally. Protruding, jutting the jaw forward, is going to be largely the external pterygoid firing bilaterally. TMJ click, condyle repositioning, that I'm just going to leave for when we have a chance to workshop. There's a technique for resetting the disc. There's a couple of different ones that I'd like to show you, a couple of different ways to gently manipulate the jaw. Very effective ways that you can, especially once you've done the work with the muscles, you can get the disc to kind of reposition. Opening click, this is going to be a muscle imbalance. And this will be one of the most common things you'll find with people. There'll be a click when they open or a click when they close. They might have been aware of it for a long time and even forgotten about it. So the temporalis is going to be an imbalance between temporalis, digastric. A closing click usually is an external pterygoid problem, usually the superior division. That's the muscle that manages and tethers the disc as the jaw is moving back and forth. And there's a manipulation technique I use that I'll teach that is really good at kind of resetting that disc. So this is the protocol for recapturing, but like I say, we'll leave that for the workshop. Next up is going to be excuse me, hologramic techniques. So we're going to stop this video there now, and this is where we'll take up next.